Coming up next here on C-SPAN 2, a Senate committee hears from health officials about efforts to prevent and treat the SARS virus in this country. Later, President Bush makes remarks about a global HIV/AIDS initiative. And after that, you'll hear from Senate leaders about their legislative agenda. Now, the hearing. Testifying first is Dr. Julie Gerberding, Director of the Centers for Disease Control. Later, Canadian health officials talk about their experiences with SARS, especially in Toronto, one of the hardest-hit cities in the world.
Have the folks from the press wrap up. Great. This is our second major hearing on the issue of the SARS virus and its implications for the United States and our role in trying to abate it as much as possible, certainly here in the United States, but also internationally. Senator Kennedy will be joining us in a few minutes, as I understand, but we should get started because we have a lot of important witnesses who are actively involved in the fight, and we want to make sure that they're not taken away from it any longer than necessary. But it is important to get out as much public information as we can on this issue so that the American public, and to the extent we have international viewers, they can appreciate the effort that's going into trying to identify and contain this virus and be sure that their government is doing what is necessary in order to accomplish this and what we have with the tools that we have available to us. Unfortunately, it continues to be a rampant problem, especially in China. There is, as the doctor has said before, who's Dr. Gerberding, no vaccine and no, right now, antibiotics which appear to be able to be used to limit its impact. And therefore, it is important that we identify quickly people who may have symptoms of SARS, especially those coming into the United States. That we identify those individuals and that people sort of self-police themselves as they come back from regions which may have high infection rates. And if they have the sense that they have cold symptoms, that they call their medical provider, call them, not go to them, hopefully, and find out what the next step is. And so it's important that American citizens understand that that's their obligations as good citizens to pursue that course of action. Today we're going to hear from Dr. Gerberding, who is head of CDC and is doing an extraordinary job for us on this issue and many other issues. We're also going to hear from Dr. Gully, who is with Canada Health Canada, which is the national health organization in Canada, and Dr. Young, who's with the province where Toronto, is with Toronto and is involved in the fight there, Ontario, province of Ontario. The issues before us, I think, remain. How far down the road are we here in the United States in being ready to handle this threat? We have been lucky so far. The super spreader who must have or may have hit Toronto could have as easily landed in Boston or New York or Los Angeles or even Manchester, New Hampshire. We have just been fortunate in not having had the problems that Canada had. And the question is, now that we have been so fortunate, how can we make sure that we do take advantage of our good fortune and address the problem aggressively? Clearly, China has still got a huge problem and does not appear to have its arms around that problem yet, in my opinion. But other nations, such as Vietnam and Canada, appear to have taken different tacks and have been reasonably successful, and we look forward to hearing from those nations, Canada especially, today. The border with Canada is, of course, the longest undefended border in the world, and we're very proud of that. But the issue now is, do we need to defend ourselves relative to the issue of SARS coming across the border? And if so, how do we do that, and how do we do it in a constructive way that assists not only our nation and our people, but also our neighbors in Canada who are such important and good friends to us? So we look forward to the testimony today. The number of other issues have been raised, but and we'll proceed to address those as we move down the road of the hearing. But first, we want to hear from Dr. Gerberding and get her thoughts and input on how we should be proceeding, specifically where we are and how we should be proceeding. Dr. Gerberding.
Chairman Gregg, I appreciate so much the opportunity to be here to do this and the interest and leadership that you and your committee have shown in this very challenging epidemic that we're dealing with. We're striving very hard at CDC to maintain transparency about the status of the epidemic and the steps that we're taking to combat it. And this is really an important opportunity for us to update you and get your input, but also to make this visible to all of the people in the country who are interested and have a stake in how it's going. So we just really thank you. I also thank Health Canada and my colleagues who have been working side by side with us as we've come to develop international strategies for managing SARS, and also my colleagues from Ontario who are here today to testify as well. The concept of collaboration is a word that we use often, but I think the spirit and the actualization of this particular outbreak response is exemplary of what true international collaboration can be. It also illustrates the consequences when that kind of international collaboration fails. What I thought I would do is give you a brief update on the status of the SARS epidemic, and then discuss for you the current approach that we're taking in the United States, as well as what some of our long-term strategies may be as we begin to transition from the beginning of this problem to sort of the ongoing concerns that we need to look forward to and anticipate in the future. If I can have the first graphic, this is a map, international map. You've seen this kind of information before, but it emphasizes the widespread distribution of SARS on a global basis. Today, WHO is reporting 5,050 cases in 28 countries. 321 deaths have been reported. That gives a crude mortality rate of about 6.3% internationally. But of course, that mortality rate is very variable from one country to another, and it may, in fact, go up as the time lag between when cases are detected and people either recover or die from illness. The statistics catch up with the events internationally. From a domestic perspective, today we're reporting 220 suspected cases. These are people who have traveled or who have had direct contact with SARS patients and who are ill but don't have the full-blown pneumonia. We are also reporting 52 probable cases. These are individuals who do have the pneumonia. And today, shortly following this briefing, CDC will be releasing a dispatch from our Morbidity and Mortality Weekly Report that will provide for the first time for the U.S. Case definitions that include laboratory criteria of infection. And so we are adding to the concept of clinical status of the patients, which would be mild illness, moderate illness, the suspect case definitions, and then SARS, the severe illness with pneumonia. Another dimension, which is laboratory confirmed, meaning one of the three testing criteria for laboratory results has been positive, or laboratory negative, meaning those tests are negative, and then finally laboratory indeterminate, either because we haven't done the test or the test results are pending. This will add a degree of precision, although at the current time the status of our tests is not accurate enough, or at least we don't know the accuracy of the test at this point, to indicate that if someone has a negative test, they don't have SARS. We have more to learn about the interpretation, and so we're putting this out as an additional tool for classifying individuals with the suspicion of SARS, but we are continuing to cast a very broad net for our isolation precautions because we don't want to overlook any potential infectious people that could serve as a vector of transmission to others. So I'll be happy to make that dispatch available to you when it's published and disseminated later today. We have a current strategy in the United States that emphasizes several key components. First and foremost is, again, international collaboration. We're extremely fortunate and grateful for the efforts that WHO has made to coordinate the overall global response to SARS. Their leadership in the investigation as well as the laboratory coordination has unprecedented, and I think certainly accounts for why we were able to learn so much so quickly once the WHO alerted the international community to the evolving SARS problem. But domestically, our first priority is on protecting travelers, since travelers are the individuals that seem to be at greatest risk of SARS right now on the international scale. And our protection of travelers consists of information for outbound travelers as well as information for inbound travelers. Outbound travelers are continuing to receive information in the form of health alerts, travel alerts, which basically say, be aware that there is SARS in the country that you're planning to visit. Don't go to places where SARS is being transmitted, and use common sense precautions to protect yourself. A higher level of precaution is a travel advisory, which says there is concern for travelers acquiring this infection in the country. It's important that you not go there unless you have absolute reason to be there. In other words, non-essential travel should be avoided to an area. Right now, mainland China, Hong Kong, Taiwan, and Singapore are countries in which we have travel advisories. We had a travel advisory in Vietnam as well, but it turns out that they have been able to successfully contain the epidemic there. There is not evidence of ongoing risk to travelers, and so in the last 24 hours, we, as well as WHO, took Vietnam off the list of countries where non-essential travel should be avoided. Our efforts on behalf of travelers include the mechanisms for captains on airliners and other vessels to have the requirement of reporting an ill passenger to a customs official as the flight is inbound, and then for CDC quarantine investigators or other customs officials to intervene, board the plane or the boat, and evaluate whether or not the ill passenger is suspicious for SARS and could be posing a risk to other passengers. Finally, of course, is the ongoing distribution of these health alerts. This is one that has been updated since my last hearing here, and I can assure you that it is now in Spanish and French as well as several other languages, and we are making these health alerts available to airplane and vessel passengers. In addition, these are being distributed at the 13 land crossings between Ontario and the United States, where we have approximately 5 million travelers cross the Ontario-U.S. border every month. So we've had an enormous collaboration and cooperation with the Canadian government, with Health Canada, and with the Ontario health officials. We've also benefited from the interaction with the Department of Homeland Security and the customs inspectors, who have been totally supportive of this major step up in our alerting process. So, international collaboration, protecting travelers. The third component of our current strategy is to detect cases of SARS and isolate them as quickly as possible. And the public health community and the clinician community in this country have done an absolutely outstanding job of early detection, but also of implementing the kinds of airborne and other precautions in the healthcare setting that will protect our healthcare workers. Our observation so far has been that in the countries where SARS has really evolved into the community, the weakest link in the chain is the healthcare system and the spread to healthcare personnel. So we are putting huge efforts into making sure that we have the best possible protection in the healthcare environment from the moment the suspected patient has the initial contact with anyone in the system. Isolation in our country for SARS cases has been almost entirely voluntary. This is typical pattern of maintaining and managing infectious diseases in hospitals, but we also have in our state and local health officials the authority to require a patient with SARS to be isolated should that ever be necessary. Finally, the fourth important component of our strategy is to protect the contacts of SARS patients. That includes, in this country, a series of efforts. Number one is to identify the contacts, and our health officials have done a great job of looking for potentially exposed people. Second, putting those people in an active monitoring program where they are contacted at a regular basis to make sure that they're not identified as having early signs or symptoms of SARS. And then if they do develop anything, to alert the healthcare delivery system before they get there so that those infection control precautions can be in place. One other important issue here for us is the fact I mentioned early on is that we are working extremely hard to be as transparent about what's going on and are putting a strong effort into communication. I wanted to give you some impression of how active our communication system at CDC has really been. We've triaged more than almost 5,000 press calls. Our hotline has answered over 22,000 calls for information from the public and about 2,300 emails. We've sent updates about the clinical information to the 25,000 clinicians who have signed up for the CDC Clinician Registry, and 67 clinical professional organizations are taking our information and redistributing it to their membership. So we're reaching hundreds of thousands of clinicians around the country. Our website has been accessed by more than 6 million people on SARS so far. And we've done a satellite broadcast internationally in conjunction with WHO and clinicians in Asia that reached more than 40,000 clinicians around the world. We've sent 16 health alerts. We are now conducting telebriefings with people in the Asian American community because we recognize the ongoing concern about fear and discrimination that they're having to deal with. And lastly, our website increasingly has more and more information that's translated into other languages so that the international community can benefit from the information. This isn't an exhaustive list, but it helps, I think, to illustrate that we are making every effort to get information out in all of the ways that we have at our disposal to do that, and we're always open to input or suggestions about how we could do that better. A couple of quick points on the success of that effort. We have been working with collaborators at Harvard and getting some information about how the public is really perceiving SARS, and some preliminary information from this suggests that about 93% of the public know about SARS or have heard of it, and that's a good thing. It'd be hard to miss it, but occasionally people don't pay attention. 89% of people said that if they got ill with a flu-like illness, it would be very important to tell their clinicians about recent travel. That's so important to us to know that that message is getting through to the average person in the community. 94% said that if they had SARS, they would agree to be isolated. And about 92% said if they were exposed to someone with SARS and were asked to have voluntary quarantine, they would agree to voluntary quarantine for a period of 10 days. So our public is informed. They are willing to cooperate with public health measures, and I think that's a good thing, because right now all of the steps that I've described to you are primarily a public health strategy, which is the tried and true old-fashioned way of dealing with an epidemic. But until we have a vaccine or we have antiviral treatment, this is the best we can do right now, and we will make every use of these tools. And if the problem evolves in this country, we're prepared to take additional steps to focus on containment. We are looking at containment as the primary goal. People often say, what's the worst case scenario? The worst case scenario is ongoing spread, such as we anticipate with influenza sometime in the future. And we do have a preparedness plan for pandemic flu, and we are adopting that plan so that we can be prepared for coronavirus or SARS if it did evolve in that direction. I think the best case scenario is that the containment efforts will uniformly be successful and this will all go away. Increasingly, that seems highly unlikely, as you mentioned, given the situation in China and other countries where there's ongoing transmission. And finally, the most likely scenario, at least as it looks from our vantage point right now, is that we will have to work hard at containment, but I think we've proven that containment can be successful in getting a handle on the problem, and we hope that this will prove to be a seasonal virus and we can buy some time if the weather changes and the transmission decreases, but of course we can't count on that, and so we need to be prepared to continue this effort until we have the other tools. And I would just make reference to the Institute of Medicine's recent report within the last few weeks on the microbial threats to health, which makes the major statement that these emerging infectious disease problems are now part of our life in the global community, and the kinds of things we're doing for SARS, we can anticipate we're going to do again and again as our universe becomes smaller in time and geography, and we need to learn lessons from SARS and apply them more broadly for future preparedness. And the last point along those lines are the 2 CDC strategic plans for protecting the nation's health in an era of globalization and preventing emerging infectious diseases, which speak to many of the issues that have served us well in the current situation. So I again, just thank you so much for your support and leadership, and for having this hearing so that we can provide this perspective.
Thank you, Dr. Gerberding. And those numbers which you cited, the polling numbers that had been done at Harvard relative to people's receptivity to being quarantined, to making sure they contact their provider if there's some sort of flu situation, are extraordinarily encouraging, and I think they reflect the great work that you folks are doing at CDC in this transparency effort of getting the message out, making sure people understand what we know and how we know it, and what we need to do from here. And so I congratulate you on that. In that arena, however, I'm wondering, you mentioned where you don't see us containing it, essentially, in China, and as a result, it's continuing to grow as a problem. Can you go a little bit more into that? I noticed that the Philippines now has the issue, and Taiwan, China, Hong Kong, obviously. What do you see as the game plan for dealing with those nations which were behind the curve, and as a result generated the problem to a large degree? Do you think that they can get a handle on this? Can they get their arms around it the way Vietnam and Canada have, or can they not?
I don't know for sure. We are increasingly confident that the information we're getting from China is reliable. We don't have teams in all areas of the country yet, but the doors are certainly more open now than they were in the past several months. And so as part of the WHO effort, we have CDC people on the ground, and we are getting information. And the best picture of the SARS epidemic in China right now would be characterized as variable. There are some regions like Beijing who are having an extremely difficult time containing this, and other cities where the problem does not seem to be widespread or present at all. And obviously that could change. There's a lot of travel within China, and so they would need to be able to exercise the same kind of containment procedures that we're using in other parts of the world. I wish I had a crystal ball. I would try to project the situation there, but I think there is very little suggestion right now that it's going to go away anytime soon in China. And the Hong Kong scenario is suggestive that they are making strong progress in containment, but there are still occasionally new cases being reported there. But we did see a remarkable curtailment of transmission in Vietnam, even though what started there with a very serious outbreak in the hospital. That situation with fairly reliable data seems to be coming under control, and likewise in Thailand, where there was not ongoing transmission. That's very variable. You made reference to super spreaders or hyper transmitters, and that's a term that is useful in describing clusters of patients and why someone is especially associated with a large number of exposed and infected people, but we don't really know if there is such a thing. It may be that people who are ill are infectious because they have a lot of virus, and when you take the combination of someone who's infectious and a situation where there is inadequate protection of the context, you end up with that cascade or a cluster that sets off the chain of transmission. So we've got a lot to learn about why some people are transmitting and others aren't, and why some people have severe illness and others don't.
How far are we away from being able to produce a reliable test that is that you can deliver in a timely manner, that gives you a pretty good reading as to whether or not a person has just got the flu or whether they have SARS, and isn't that critical to our capacity to contain?
We are certainly at CDC putting a high emphasis on that diagnostic testing. By the end of this week, we're sending the first kits out to the state labs that have the tests. We have two main categories: the PCR tests, which can identify virus RNA in the respiratory tract or the blood of some patients. We also have the antibody test, which is performing as a much better test for discriminating SARS from other patients. Unfortunately, we can't interpret it until 21 days after the person has been ill. These tests are still under evaluation, but FDA is working side by side with us to get them into a status where we can use them for clinical care, and that is an imminent step that we'll be taking very soon. We also have, as you know, posted the RNA genome on the website, and I have documentation from numerous private sector companies and biomedical, biotech companies who are interested in working on diagnostics or vaccines. So we are taking the steps necessary to make the information materials available to the private sector so that they can contribute to this effort. And that in the context of an international community who's doing the same thing, including our collaborators in Canada. I think we're very close to a reliable diagnostic test, weeks, not months or years, unlike the vaccine or the treatment, which is a long way away.
To what extent, if you can just confirm again that we believe this was not man-made, that it came from animals to humans, that'd be good. But secondly, to what extent are we seeing the disease mutate, or do we expect to see it mutate so that even those diagnostics might be made less than effective?
The virus itself is a single piece of RNA. It's a single-stranded virus. It's actually probably the largest RNA virus that we deal with in humans. And it has, it's in a family, the coronavirus family, that is notorious for recombination, meaning exchange of pieces of the virus with cousins, as well as making mistakes as it replicates. We are so early in this epidemic that we haven't documented any association between changes in the virus and the pattern of transmission or the severity of illness. But it would not be surprising for this to occur with this particular kind of virus. And that is something that we have to be monitoring, because it very well could at least interfere with the PCR test and potentially with the antibody test as well. So it is a concern. It will also have implications for vaccine treatment. But we haven't identified that as a problem yet.
And we still don't feel it was man-made. We feel it was transferred from an animal to a human.
The pattern and onset, as we understand it in China, is really most consistent with a naturally evolving coronavirus. I don't have any evidence to suggest anything intentional at all.
And lastly, the two prominent leaders in this issue in Canada have joined us today, and I would just be interested in CDC's evaluation of where Canada stands and what we can learn from Canada.
But I look forward to being updated from our nearest neighbors, but from our interaction, and we do have a CDC employee at Health Canada, and Health Canada has a staff member in our operations center at CDC, and we also have a team in Ontario working in the healthcare system, so I think our information is reliable. We understand that we need to be cautiously optimistic about Canada. They haven't had a new case in, I think, 7 days, and there is not evidence of ongoing community transmission there. That's why they are not on our list of travel advisories, but we are doing the alerting at the borders and for outbound passengers. And if we are continuing in this trajectory, I think we will work very hard with our collaborators in Canada to make sure that the rest of the international community appreciates that the disease is contained there, at least right now.
So the Red Sox can go there and beat up on the Blue Jays.
I'm not going to get into sports issues.
Thank you very much, Mr. Chairman, and I thank you for having this hearing again. It's enormously important. And I want to thank Dr. Gerberding and all of those at the CDC. I think it's important Americans understand what a center of excellence that is, the Center for Disease Control, and how well it's being led. And we are enormously appreciative of your leadership, Doctor. And it's been 3 weeks now since you were last testified. Disease has spread to 27 countries. In fact, every continent's claimed 200 more lives, sickened 2,000 more patients. And although SARS remains a global threat, it has provoked an extraordinary global response. The health agencies around the world have responded forcefully to SARS. Scientists have labored day and night with extraordinary results. They've deciphered the complete DNA sequence of the virus. They're developing sensitive new tests to stop infection or testing ways to cure the disease and develop the diagnostic tests that Senator Gregg had referred to. The public health agencies have responded effectively to prevent the local outbreak from becoming national epidemics. And as was pointed out, a result of SARS on the decline in Canada, Singapore, and Hong Kong. In Vietnam, the wildfire of SARS has been extinguished. Just 1 hour ago, World Health Organization announced it's lifting advisory against travel to Toronto, and the world owes enormous debt to the dedicated health professionals who work tirelessly to protect health from the threat of SARS. From Boston to Los Angeles and Seattle to Miami, the story is the same, but budgets have been cut to the bone. If there is no excess capacity to meet the new challenges like SARS. According to Dr. Kevin Stevens, the director of New Orleans Public Health Department, we have very few resources, and we should have a SARS outbreak. We are very poorly prepared. Dr. Laureen Muscola of Los Angeles County Department of Health and Services said that in California, about 2,000 people die every month from unexplained pneumonia. We have dealt with SARS to the detriment of other diseases. One of the most effective ways to fight the spread of SARS is quarantine, yet many of the nation's major health departments be hard-pressed to use even this basic tool of disease containment. Philadelphia, for example, there's no city-owned hospital, and the health department has no funds to set up quarantine facility of its own. It would instead have to rely on hard-pressed independent hospitals to house SARS patients who need to be isolated. Seattle has only limited facilities to isolate contagious patients. That city is already facing the highest number of TB cases it's seen in 30 years. With only 2 full-time infectious disease physicians to serve over 1 million inhabitants, the city would soon be overwhelmed by a major epidemic. In Boston, the health department is already stretched thin, answering over 200 calls a day from people worried about SARS, and there are no confirmed cases in the city. In cities across America, there are gaps in our ability to contain a SARS outbreak should one occur, and we need to address the deficiencies, and we must address them now. Congress has tried to reduce these deficiencies in recent years, investing more in our defenses against bioterrorism, and these investments are clearly paying dividends now in the fight against SARS. But their effectiveness have been undermined by the cuts in funding for hospitals, health agencies at both federal and the state level. A survey by the American Public Health Laboratory Association found that 30 state health laboratories face budget cuts this year. Only 7 expect their budgets to remain the same, and no one expected more funds. In our state laboratory in Massachusetts, estimate that it'll need hundreds of thousands more dollars to test tissue samples for SARS. With additional funds, they could determine whether patients truly have SARS or a sniffle in a fraction of the time it takes now. The quicker the decision, the more likely we are to keep an outbreak from spreading. This is the situation across the country. I've had my staff call the major cities of the countries and the ports of entries, and I've just given you a taste of what is out there happening. We have this extraordinary success under your leadership with CDC. We know the devastating impact that something like this can have, let alone if it was the threat of bioterrorism on it, this thing. What do we say to the people at the local communities about what kind of help and assistance that they are going to receive in terms of trying to deal with this kind of challenge locally? What kind of hope can we give them?
Well, first of all, let me just say that I am aware of the difficulties that state and local health agencies are having in this arena and in other arenas, and as I've tried to say as publicly as often as possible, our public health system is suffering from decades of neglect, and we can't fix it with a one-shot bolus of resources or even a sustained investment at the level that we're making in terrorism without really thoughtfully planning and focusing and prioritizing the capabilities to respond to these new threats. We are very grateful to your leadership and Chairman Gregg's leadership, Senator Frist's leadership, and the whole committee for your support of the improvements in public health and public health infrastructure. And we've made progress. I really would like to emphasize that we are responding, I think, as well to SARS as we are because those investments are paying off. But there is a lot more work to do, and the appropriation that Congress made, the $16 million that was included in the supplemental budget, we obviously need to make sure that some of that resource goes to the states to help out with the additional burden that this is placing. And we're taking a lot of steps now to try to make sure we can understand and document the true needs as well as the true economic impact of what they're trying to do. It's a moving target right now. It's difficult to predict what they will need, but we need to take it seriously.
I appreciate, and it's not entirely fair to ask you about the resources that ought to be necessary, but having your own, having gone through the SARS period and having seen what good preventive work means in terms of getting a handle on this. We know that there's still a lot of danger out there, but the progress that's been made has been enormously important, and people ought to understand that. But we also want to try and make sure that we're going to have to benefit from this kind of experience. If we're going to be facing other kinds of, whether it's dealing with the smallpox, which is the administration's program, we've been able to work out the program now. That's costly in terms of being implemented, plus the potential danger in terms of from bioterrorism. So this is an enormously important area of need, and at the same time we're facing the further cuts in terms of hospitals, about $1.4 billion at a time, and we're returning about $450 million to them to help and assist them. But we're trying to prepare them for a surge capacity at the time that the roofs are leaking. I mean, we've got to try and I think make the investments that are necessary in terms of protecting our people at these local community levels. And we see what a difference it makes when it's done that way and when we've had strong leadership. And we thank you very much for all you've done and all you continue to do. And my time is up, Mr. Chairman.
Thank you, Senator Kennedy. We're going to limit the first round to 5 minutes. Both Senator Kennedy and I took about 5 minutes. Senator Reid, you were next. Did you want to ask some questions? Or were you heading out?
Thank you, Mr. Chairman, and thank you, Doctor, for your testimony today and your leadership at the CDC. Basically, our strategy today is containment, and I think consistent with that is monitoring. Could you elaborate on the procedures you're taking to monitor, particularly outside the United States, to get an advance notice of potential developments?
When I mentioned monitoring earlier, I was speaking about the monitoring of exposed people within this country, and we have asked the state and local health officers to implement systems that they can contact people who've been exposed to SARS patients in the last 10 days and check in with them to make sure that they're not developing the early symptoms and helping triage them to health care if they are. Internationally, monitoring is more in the lines of surveillance for cases that are occurring there, but we are totally supportive of the WHO recommendations that passengers be screened for illness at the time of departure so that there is not exposure en route. And we're also, of course, continuing the ongoing effort to alert returning passengers of the need to get medical care if they develop symptoms within 10 days after their departure from a country where this is ongoing.
But you don't have a more comprehensive surveillance plan, for example? These are just airline passengers you're talking about. What about people leaving via ship or moving over land to different countries and then leaving from?
The health alerting mechanism for returning passengers applies to the airline industry. It applies to the vessels that either come directly or indirectly to the United States. And in Canada and the Ontario border, it also applies to car passengers. This is for direct flights coming into the United States, we have a very close to 100% contact. For indirect flights, for example, if a passenger leaves China and goes to another country before returning to the U.S., we're getting close to 98%, but we do occasionally miss flights in that domain.
So I presume then you feel that the surveillance system in place is adequate to give you fair warning as this disease continues in China, certainly.
I think the alerting of incoming passengers is going very well, and it's working. We know people are responding to this information and getting medical care. A broader issue is our capacity to detect these problems when they start. And, you know, the first cases of SARS were in China in November. We got a WHO alert on March 12th. That's, you know, 5 months down the road. And that's the kind of system that we need to address in collaboration with WHO as well as the ministers of health in the global community. That's not acceptable. And this problem got started because we didn't have an early detection system to tell us what it was.
And do you have a plan to not only design such a system, but to request whatever funding that we must make available for such a system?
We do have a plan for the system, and I have to talk with you about the funding and support for it. Some of the terrorism dollars from the appropriation have gone into a program to create a better sentinel detection system internationally, but I think we have a lot of work to do before we really have a seamless system that we can rely on fast enough and early enough to tell us that there's a new threat. And a related problem that I specifically struggle with at CDC is that we can't get specimens to the United States. We were aware that there was a mysterious pneumonia brewing in China and in Asia. We got our first specimen, I think, on March 13th, which was one from an American citizen in a hospital in Hanoi, but it took us a really long time to get all of the patient specimens that we needed to begin to work on this virus because the airlines were afraid to fly the specimens to the U.S. And we have no independent authority to go and get specimens, and it's really a factor that has slowed us down in these international response efforts time and time again. It happened here with SARS. It happened with anthrax when we had anthrax specimens in Chile and we couldn't get them to the United States, even though the Department of State and DOD and everybody was trying desperately to help us. So that's another component of the early warning system that we need to resolve.
Is that that would require a legislative remedy that this committee should consider?
I'm not sure. We have authorization, as I understand it, to lease aircraft at CDC. That's how we manage the stockpile plane. But there may be additional authorities that are necessary, and I will certainly be happy to get back to you with that specific information.
Let me change slightly the subject. From your comments, it seems that this might be the face of things to come, that with globalization, with these inadequacies and at least surveillance and early alert, that we could see other viruses following. And as the chairman pointed out, this virus appears to be mutating, which is the stock of all these science fiction thrillers, the mutating virus that is detected too late. Does this give you concern that we might see a series of different viruses or illnesses sweeping across the country?
I don't want to be alarmist, but I think history is already teaching us that that's the case. We've seen the emergence of Nipah virus. We've seen hantavirus. Now we see the SARS virus. We had the avian flu virus that fortunately didn't spread easily from person to person, so we were able to attenuate that particular problem, but there's no guarantee that the next flu strain to emerge is not going to be as transmissible or more transmissible than SARS. That's really the message of the Institute of Medicine, is that these kinds of emerging infectious diseases are part of our life, and we need to scale up and respond to this proactively because we aren't going to be able to stop their emergence.
So deterrence is not working. We have got to go into preemptive mode?
I think so.
Thank you, Mr.
Recognize the majority leader when it does come, and I asked him if he wants to proceed, and said he'd rather hear from you first.
Good point. Well, thank you very much, Mr. Chairman, for organizing this hearing, and to you, Dr. Gerberding, and all the people at CDC who've been working so steadfastly and persistently on this. SARS is a global menace and a local threat. Germs just don't know borders. There are 3 possible cases in my own state of Maryland. And Marylanders want me to ask, what is the government doing to contain SARS, to find a cure for SARS, and also to prevent it from spreading? And we also need to be talking about a communication strategy about what does the public need to know about SARS, but what do they need to know about how to protect themselves? And fourth, another issue is lessons to be learned from SARS about how we can protect ourselves from these epidemics, whether they are triggered from who knows where, or whether they come from a malevolent predator. So my question goes to also the whole issue of public health infrastructure and what I call dual use to protect us from something like SARS, but also from something like smallpox. Let me go to that because Senator Kennedy raised those issues, and I would like to raise them as well. When some years ago we found that the public health infrastructure was tattered, it was worn, and in some places even non-existent. Local health departments not even having fax machines. The majority leader led this committee, a public health subcommittee, and we worked on a bipartisan basis to upgrade it. Then, with bioterrorism, we put $1 billion into the CDC budget. Could you tell me, number one, as you're struggling so valiantly with SARS, what are the lessons to be learned to protect this nation? Number two, what is the status of our public health infrastructure? Do we have the biosurveillance? Do we have the monitoring? Was $1 billion enough, or was it a down payment so that we could act in this year's appropriations?
Thank you for your question and also for all that you've done to get us started on rebuilding our public health infrastructure. There are a lot of lessons that I think SARS illustrates. The first lesson is that emerging infections are a fact of life and we need to get used to that. I think it's also teaching us that the whole public system has to be intact. We're only as good as our weakest link. And if we have one failed public health system or one failure to be able to take the steps necessary to contain a problem like this, the whole country could suffer. The third lesson is the importance of the continuity of public health with the healthcare delivery system. We've got to have both capacities, a viable and vibrant and robust medical care system with informed clinicians, but also beds and surge space and training, but that has to be immediately linked with the public health community. And I think, for me personally, one of the most important lessons is that we have to have public health research to identify what is the best way to do all of this. We make it up as we go, and we have a long experience and some success stories to build on, but looking ahead at the public health needs of the future, there are a lot of unanswered questions, and we've got to know faster how we can deal with these efforts and mitigate the consequences of a problem like this.
But Doctor, are you satisfied that local public health infrastructure, public health agencies are really fit for duty for this new area? In my own city of Baltimore, thanks to the great help that came from the state of Maryland through bioterrorism, in our own city we have a vigorous biosurveillance program to be ready for homeland security that's now serving us well in SARS. Dr. Peter Billiamson, our local health department official, was prime time. Thanks to your alerts and your information back right in the local community, using then our biosurveillance techniques that were citywide and even community, metropolitan-wide, we could pick up those cases, and Dr. Billiamson himself went to the apartment building where one of those was, the information went out. Baltimore is calm because we have confidence in Dr. Billiamson and our public health network. We're in the shadow of Johns Hopkins and the University of Maryland. We're a wink away from the NIH. Not everyone is. So my question is, and particularly these large metropolitan areas that could be hit so hard, that are so high risk, do you have confidence that they're ready, or do we need to make a greater public investment? through you, meaning CDC, which are to really develop this kind of essentially combat-ready systems?
Well, as you described, Senator, the public health system is tattered, and the investments that have been made so far have helped a lot, and we are certainly much better off today than we were even a year ago. But there are certainly districts and local health communities that do not have the kinds of capacities that you have in Baltimore. In particular, Baltimore has an outstanding biosurveillance network that is directly linked to the healthcare delivery system, and that is exceptional. And I would love to see a system like that functional across the entire United States, if not the globe. So we do have many more steps that we can be taken, and I think the investments do need to be sustained over time because we can't. It's not a one-shot fix.
Well, thank you, Mr. Chairman. Does that mean my time's up? Okay. I would just like to thank you and really all of the public health people that have been working around the clock to do this at the federal, state, and local levels. I mean, really, God bless you. You really are saving, I think, lives.
Thank you. I would really like to thank you for making that comment, and actually all of the people who have commented on CDC and the public health community, because while I may be here providing information, there's 400 people in Atlanta and many internationally deployed who are doing the hard work of responding to this, and that doesn't even count all the folks in the medical and public health community, so they are the true heroes of this.
Senate Majority Leader.
Thank you, Mr. Chairman, and thanks for holding the hearing today. An important time in an evolving crisis, global crisis, that 2 months ago or 3 months ago, none of us would have fully anticipated, although we all were aware that emerging infectious diseases were on the horizon, would continue to occur, and this is, as I've said before, one of many that we are likely to see in the future. So the time that we spend with it, the dissection of the response both in the United States and Canada and China and Taiwan and Vietnam is something that is both important to do and to dissect it in such a way that we can both learn so that for the next emerging infection we will be able to respond quickly, appropriately, and I'm speaking internationally as well as domestically. Dr. Gerberding, thanks for your leadership. I do have the opportunity to tell you that on a regular basis, and I thank you for that. I had a fascinating experience over the last 2 weeks and had talked to Dr. Gerberding and a number of other people before going to China, but about 2.5 weeks ago, made a very conscious decision, in part as a physician and in part as someone who's familiar with infectious disease, who, in fact, I really spent most of my adult life fighting infectious disease in my transplant patients before coming to the United States Senate, but did make a conscious decision to go to China at a time, and to Taiwan and South Korea and Japan as well, but especially in Taiwan and in China, because it was unclear at that point in time whether or not accurate reporting was underway from that country. In fact, the consensus was that there was a cover-up of data from a centralized Communist Party and centralized government. And indeed, what originated in Guangdong province in January had been covered up aggressively, not only in the province there, but almost more inexcusably in Beijing itself, because in Beijing you do have the potential of infrastructure supporting and surveillance, probably more so in the provinces at large. About 12 days ago, our delegation of 8 United States senators arrived in Beijing, and the President Hu Jintao and their Minister of Health at that time knew that we were coming, and up until about 3 days prior to that, they had simply not been willing to release statistics. Now we know that over 3,303 probable SARS cases, that's the most latest statistic as of this morning, and over 148 people have died that have been reported from the virus in China. But 12 days ago, those figures down, instead of being 3,000, were several hundred, and instead of 148 reported deaths were in the teens. We did have the opportunity 8 days ago, 9 days ago, to talk directly with the leadership both of the Communist Party as at the highest level, the Minister of Health, and then the acting Minister of Health, and also the President of the country, President Hu Jintao. We were very direct in our conversations with him and didn't accuse them, basically said that we are well aware that that you have been withholding data, and their response is that we hadn't been collecting the data, and we have an inadequate public health infrastructure, which they do, to really collect that data. But in addition, it was very clear that they were not releasing data nationally within the country, but then also globally as well. It gave me a great deal of pride to see appearing on the ground, not at first, but the World Health Organization both arrive, and all of us know the stories that as they arrived, SARS patients were put into automobiles, put into ambulances, were actually taken out of the hospital so that the surveillance could not take place. And this happened while we were on our Asia trip. Again, I was very direct, speaking as a physician, as somebody interested in infectious disease, but also as a political figure here in the United States, that this cannot be tolerated. Let me say that the response of both the Communist Party as well as President Hu Jintao was very positive. With a recognition, the premier 2 days before had said that he recognized that this was a problem. The president of China, President Hu Jintao, said this is a disaster of not only China, but potentially of the entire world. And that was something that simply they had not said before. With that, then people ask, where are we in terms of the evolution in China? And Dr. Gerberding has people on the ground there who had the opportunity to meet at this point. And I get the feeling that things are progressing well, in the sense that what is being reported as probable cases and the deaths are reasonably accurate. What is clear to me, and having been in touch on a daily basis with people on the ground in the healthcare community there, including this morning and yesterday every day, is that we need more data. We're not really getting the data of contacts. We're not getting the dates of onset of illness. And I know that we're working hard in that regard. Their response is simply, we don't have the public health infrastructure. That, yes, we can set the central policy at the top, but by the time you get down to the provincial level itself, there is no infrastructure there. There's nobody to collect the data. There's nobody to report the data to. There is no system. I share that only because, for me, it should give this committee, but especially our CDC and our government, something that we should feel very good about, in that infrastructure we've begun with the assault on bioterrorism in this committee several years ago, begun to develop that, or further develop and support that infrastructure in a very positive way. My question after that long introduction is stems on a concern of global surveillance. With China, we had a government that, maybe even at the top, the former Minister of Health himself was pretty good in the conversations. I thought, not the one that was fired and not the acting, but the former was pretty good, but nobody listened to him. Nobody at the provincial level. The head of the Communist Party didn't listen to him. The president of the country didn't listen, which shows the importance of real leadership at the top. But Dr. Gerberding, how well are we doing in terms of global communications? You may have already answered this earlier before I came in. And what can we do as a committee to facilitate, since these viruses know no boundaries, since they cross rivers, they cross oceans, they go in airplanes, they go in people's nasal passages. What can we do as a committee to increase that global surveillance to make sure that when that next virus hits, that we will not have to tolerate such withholding of data, which allows this virus to explode and to reach a point that is critical and allows it to spread around the world?
Senator Frist, first, we really appreciate the efforts you made in China. I think that there was a strong association between your visit and the fact that the doors became open and we are now able to get the kind of information that we have.
That was good.
I would also say that your efforts follow on those of Secretary Thompson, who made numerous efforts to intervene and connect with health ministers in China. At the World Economic Forum in January, I was present when Secretary Thompson tried to ask questions about SARS. That was just 2 months into the problem, and we were reassured there wasn't a problem and that it was chlamydia and so forth. So it's been a long path to get to where we are, and I appreciate the problem of infrastructure in China. Unfortunately, many parts of the world lack global public health infrastructure, and I think that we have a lot of work ahead of us if we're going to be able to get the kind of global surveillance system that you're talking about. However, we do have some pieces of it. WHO has a network. Various countries have established networks of communication, and I think our next step is to try to, first of all, identify what we have that is working and fill in the gaps where it's not working. Easier said than done, but just to illustrate what can be done, in China, CDC does have a satellite network for training that has been established in the various provinces that allows us to put out information into the Chinese public health and healthcare community. Now, that's an enormously efficient tool for disseminating information, and we just have to get it connected in the opposite direction so we can have the kind of surveillance and detection capacity that we need to find something when it first starts. We have plans, and I would be delighted to sit down with you and with the department folks in international health at HHS to look at what the priorities really need to be right now for filling in the global surveillance system. It's going to be a big task.
I think, well, and this 30 seconds, that at our meetings in China and in our meetings just last week, 8 days ago, I very specifically offered to the Chinese leaders our support for any technical assistance that the United States can provide in containing the virus. And I'm pleased that representatives from across Asia are meeting today to endorse a series of measures, both to stop the spread of disease, but also to reach out and be willing to say, yes, we can use that help as we come forward. But thank you for your leadership.
Thank you.
Senator Murray.
Well, thank you very much, Mr. Chairman, for having this hearing, and Dr. Gerberding for being here as well. You've been really good about your time. I've had the opportunity to talk to you about this issue several times as a member of the Labor HHS Appropriations Committee, and I know you're really working hard to make sure we have all the information. And I especially want to thank our friends from Canada, Toronto, for being part of this today. I think we have a lot to learn from them, and frankly, any of us could be Toronto. So it is great for them to share their information and help us learn what we need to know as well. I just have a couple of questions, Mr. Chairman. I know you want to get on to the other witnesses. And Dr. Gerberding, I continue to be concerned. I know we provided $16 million in emergency supplemental to address the SARS outbreak, but I'm concerned whether or not that's sufficient funding and whether or not CDC has shifted resources from other infectious disease prevention efforts so we can focus on SARS, and whether or not diseases like TB are being underfunded because we have this focus now. And if you could respond, I'd appreciate it.
When we started the SARS outbreak, we were in the midst of orange alert in our country because of the war in Iraq and other issues. And so from the very onset, we defined the mission, the goals of the mission, but also defined a strategy as being one characterized by parsimony, and that means trying to be right-sized in the personnel and the amount of engagement in SARS that we were committing, particularly in the international arena, since we had the expectation that we could be called upon to deal with a second threat or something related to terrorism. Since that was the characterization of the response from the beginning, I think we've been doing an efficient job of managing our human resources as well as our dollars. But clearly, this is a large effort, and the $16 million appropriation was really critical to our success. We anticipate that some of the $16 million obviously needs to go out to the state and local agencies who are directly impacted by this as well. So it's not just there to support the CDC infrastructure. The impact on other programs at CDC has not been zero, but we've mitigated, I think, any major impact by rotating people in and out of the SARS effort, not taking somebody from another center and keeping them engaged in this over the long haul. So our management has been designed to allow a comprehensive set of experts from across the agency, because it takes everybody, not just the infectious disease people. It takes occupational health people. It certainly takes the communications team. We had to activate our emergency communication system. But when people get detailed to SARS, they're there on a time-limited effort, and then they go back to their regular responsibilities so that we can minimize the impact. But I certainly couldn't say that there's no impact at all.
And I think we just have to be really careful of that balance as we go through this. The other question I had is really one of communication, because as Dr. Frist said, there is no boundaries on disease. And I know my home state, Washington State, has a great public health prevention system, public health strategies in place, but not all states do. How are you monitoring communication between states to make sure, because if somebody gets infected in one state that's in a city right next to another one, very quickly can progress that way. And also internationally, Vancouver, BC is very close to Bellingham, Washington, and there's hundreds of examples like that across both borders. Are we working internationally with other governments as we hear about these cases and communicating back and forth between states, localities, and actually internationally?
In terms of the domestic situation, the strategy for integrating information across state boundaries has relied primarily on the weekly or daily, sometimes conference calls that we have with the group of state health officers, and Dr. Selecki is obviously a major leader.
Does everybody
in that.
Participate in that?
Most of the states participate most of the time. That's not at any given time. Not all 50 are on a particular call, but in addition, that information is posted on the internet, and we have health alerts that go out broadly throughout the system whenever there's anything new. We also have a connectivity with the public affairs officials in each state that link back to CDC and with each other. So we're working very hard to maintain that seamless integration. Internationally, we have a CDC staff member at Health Canada and a Health Canada staff person in our operations center at CDC. So that's been a great help to us in having free exchange of information back and forth. And we're going to do this every time because it has made so many problems disappear. We have special groups of people looking specifically at border issues, because I think there is the international boundary where, for example, planes often fly to Vancouver before they come to the U.S. and so forth. So those very specific cases of the need for greater integration are handled on a situation-by-situation basis. But we can always do more, and if you have ideas or if there are gaps that come to your attention, we definitely want to try to resolve that.
Okay, very good. I really appreciate that, and thank you very much, Mr. Chairman.
Yeah, thank you, Mr. Chairman, and thank you, Doctor, once again. Thank you once again for your testimony and being here. Let me ask you just two quick health-related questions, then a sort of a couple of questions if I can. One is I just wanted to get a sense. I've read some reports that actually SARS appears to have less potency when it comes to children than it does older people. That's number one. And two, since we've talked, obviously a short amount of time, but has elapsed, but to what extent is there any work on the progress on any vaccines and so forth moving? Could you answer those two questions for me?
Sure. With respect to children are not immune. I think we thought early on that this might be most severe in the elderly, since the early cases and the deaths were weighted in the direction of older people. But as we see more of the international picture unfold, we're seeing severe infection in all age groups. There are a small number of infants born to pregnant women with SARS, and that's been cause for concern in Hong Kong and probably in other areas.
Is it showing up in the infants?
Well, so far, we don't have documentation that infants have it or that they acquired it in utero, but they were delivered by cesarean section, and they're premature, and they have respiratory difficulties, so they're being watched very carefully to make sure that this wasn't a problem with in utero infection. So there is a lot to learn. I think if we can get the kind of information that Senator Frist mentioned from China about dates of onset and ages and the clinical characteristics of the 3,000 cases there, we're going to know a lot more about the spectrum of illness, and we'll be able to give you a better answer to your question. In terms of the vaccine, the short answer is we're not going to have a vaccine for at least a year.
Right.
But the steps are well underway. Getting the virus sequenced was a major step. NIH has inserted the coronavirus into a certified cell line, which is an important step to getting a vaccine product started. They're starting by just simply killing the virus and inoculating it in animals and seeing whether or not that protects against re-exposure. The first generation vaccine probably will be based on something along those lines. The optimism is that our technology should allow us to do this very quickly, and that there are vaccines for other coronaviruses in animals and birds. The pessimism is that those vaccines are not always 100% protective in animals and birds, and we don't know yet enough about the immunology of the response to coronavirus infection to know how likely it is that we'll get a strong protective response, or that the protective response to one strain will cross-protect against any evolution that occurs in the virus over time. A lot of work to be done, but good progress, and I think certainly fast out of the starting gate compared to many other infectious diseases.
Thank you very much. Let me ask two quick questions if I can. One to follow up on Senator Murray's question. She asked about how often the communication that goes on with these state health directors. What are the requirements today? I've got 5 suspected or probable cases in Connecticut. At some point, I'd like to know the distinction between a probable and a suspected case. But are there requirements that those cases be reported to you immediately? Do you know of all cases that have been identified as probable or suspected at CDC?
We have high confidence in the reporting from the states.
Is it required? Is it required?
It is not required. CDC has no authority to require reporting to CDC.
Would you like to have that authority?
Well, we have a system that works, and that is based on each state develops their own regulations and statutes about what's reportable to the state.
Sounds like China.
It's a little bit different because we fund the states to report diseases to us, and so there's a carrot there, and we don't have to resort to the stick. But it is true that overall there's variability in reporting of many of the reportable conditions. This one, because it's new and because we have these outstanding relationships, I think we have a high degree of confidence that we know about all the cases.
Well, but it's troublesome in a way. I can see where we were very critical, and rightly so, of the Chinese, particularly the province, not reporting for some time, for whatever reasons, the motivations may have been. I'd be nervous if someone at some point in some state, for reasons, decided they didn't want to report cases. So I'd give that some thought, if you would. I'd be interested in knowing that. Secondly, after 9/11, obviously, here, we've all taken different steps and actions, obviously, to protect our homeland security. Tell me now what you're thinking. What happens if we ended up with a Toronto, Hartford, Connecticut, Baltimore, Seattle? What steps have you already planned and thought about that you would take in order to deal with that kind of a problem in one of our major cities? Close schools? What do you do? What are the steps you've already thought about that we would take in this country as a result now of this experience?
We have a set of stepwise responses that we would be able to scale up if the situation evolved to the point that Toronto or worse had experienced. The first step is to initiate the appropriate level of quarantine. And I use the word quarantine very precisely here. Quarantine applies to the exposed but unaffected people. And so we would initiate voluntary quarantine if necessary to separate the exposed people from the rest of society so that if they were incubating the disease, they would have little, if any, chance of passing it on. And most likely, the scenario would be that the healthcare personnel are the most vulnerable group. That's been the experience in virtually every country. So we could go from the system we have now where exposed people are monitored actively by their state and local health officials to a system where they are actually quarantined or set aside from the others until they're out of their incubation period, which is about 10 days.
Is there existing authority to do that?
We have a mosaic of authorities in states for taking these kinds of steps, but yes, every state has the authority to do that. How they do it is very variable, and one of the things that's been going on for the since 9/11 is an evaluation of what the public health laws are on a state-by-state basis. Georgetown and Johns Hopkins have initiated the Model Public Health Law Program. So far, all 50 states have done an inventory of the adequacy of their public health laws to deal with a situation like this. 39 states have proposed statutory or regulatory changes to their state legislatures to improve their public health law, and I think so far about 22 states have actually changed statutes or regulations to make sure they're up to speed. Some states don't need to make changes because their current laws are adequate, but we're working very hard to bring everybody up to the same level. And keep in mind that if the state authority fails for whatever reason, there is a residual federal quarantine authority, particularly if it pertains to interstate commerce or borders with the international community.
I'm taking a lot of time, Mr. Chairman. I apologize. I have a little more time. What I want to think about, something along the line now that we've all admitted, of course, obviously, that the mobility and the globalization issues that you've talked about, and Senator Kennedy has, and the chairman have, we might want to be thinking about pulling all this together to some degree and looking about some sort of a coordinated national approach. Much along the lines we looked at a homeland security issue here in terms of how our states interface with the federal organizations, the World Health Organization, others. I wonder if there isn't some maybe stepping back and looking at this thing in its totality in light of this experience here, so that we might be better prepared structurally. Heaven forbid that we're confronted with this far more serious situation than the one we presently seem to be in. But I want to suggest, Mr. Chairman, we might want to look at that.
Thank you, Senator Dodd, and I agree 100% with that assessment. And in fact, I've asked our staffs to start looking at that. I think CDC sort of has its hands full right now, so when we get this settled out a little bit, we'll have a chance to take a more comprehensive view and learn from this exercise, which is what the next panel is about. It leads in naturally to the next panel. So, Dr. Gerberding, I thank you very much for your time, and especially for the extraordinary effort and superb effort, I believe, that CDC is pursuing in protecting America's health. Thank you.
Thank you very much.
And we'll have our next panel join us now. We're fortunate to have the opportunity to hear from two of the folks who are on the front lines of this issue in an area which has regrettably been subject to a significant impact, and that is Canada, specifically Toronto and the province of Ontario. We have with us Dr. Paul Gully, who is the Senior Director General for Population and Public Health branch of Health Canada, and he's coming to us via video conference. And also joining us is Dr. James Young, the Commissioner of Public Security and the Minister of Public Safety and Security for the Government of Ontario. And we very much appreciate both of these gentlemen being willing to testify. They did actually have to get some dispensation from their governments to testify before a congressional committee in the United States, and we very much appreciate their willingness to do that and the openness of their government and allowing the Canadian government allowing this testimony to go forward. Canada, of course, being a good friend and great neighbor. So why don't we start with Dr. Gully, and then we'll come to Dr. Young. Dr. Gully, can you give us your thoughts?
Mr. Chairman, just
certainly, sir.
Join in the welcome as well, Dr. Gully. I think just to join my chairman here, the fact that you were able to get the lifting by the World Health Organization is a real reflection on your leadership as well. So we want to recognize that and have our American people understand that we're listening to some very important expertise from both of our witnesses here. Very important message, but we're very grateful. I join the chairman in thanking you for taking the time and your government for sharing your experience with us. Thank you.
Thank you. Dr. Gully.
Thank you very much, Mr. Chairman and Senators. I really do appreciate the opportunity to present to you this afternoon for Canada, and I certainly would like to emphasize and concur with the assessment of the collaboration between Canada and the U.S., our branch, which is equivalent to CDC in Canada and CDC after the rules of Dr. Gerberding. And I also agree with her cautious optimism. I appreciate that in terms of the assessment of the CDC. Just like to make a point, as I said, the Public Health Branch is similar to CDC and also has very similar legislative grounding as does the CDC. In terms of the context, you'll know the history in terms of it originating in China. We in Canada were aware of this through a global public health intelligence network, which enables us to serve news agencies, news wires in various different languages, including Chinese, across the world. So we were aware of what was going on in November and again in February, and then what was happening in Hong Kong in February as well as in China. We also sent out information from that to our what we call Flu Watch participants across the country, those who give us information about influenza-like illness in February. And I'll make reference to that again in just a minute. The first Canadian case came to our attention on March the 13th, the day after the World Health Organization warning. The first case in Vancouver had in fact been identified on March the 6th. It was an individual who came back from Hong Kong, and as a result of the prior warning of what was happening, this person, because of the respiratory symptoms and had come back from abroad, was put under respiratory isolation. It was unfortunate that the first case in Ontario was a woman who came back from Hong Kong, had stayed in the Metropole Hotel, became ill and died at home. And a member of her family who acquired SARS came to an emergency room in a hospital and spent a number of hours there, and it would appear transmitted SARS then to healthcare workers and other patients. Unfortunately, because the person had not arrived back from Asia, and in fact hadn't had any known connection, apparently, and that history wasn't obtained, with Asia, then the possibility of SARS or an atypical pneumonia from Asia was not identified. I think it was a question of luck in terms of, therefore, what happened then, and as I think has been said a number of times, could easily happen elsewhere once it gets into a community. And from that individual to that hospital, other hospitals then became the genesis of the problem in the Greater Toronto area. And Dr. Young can tell you further about that. At the present time, we've had 146 probable cases in Canada. At the moment, we just have 39 hospitalized cases. All the others have left hospital. And indeed, a number of those are getting better. They are staying in hospital until they're completely recovered. We have unfortunately had 21 deaths, which is probably a reflection of the transmission to hospital patients and their family members, and those hospital patients have tended to be older, and therefore in the vast majority of those cases, those deaths have occurred in elderly people. So the transmission, as I said, occurred to healthcare workers and patients in 92 of those probable cases. Home contact of healthcare workers and patients in 43, so close contact in the home situation. And then 2 specific community settings, again traceable back to the original hospital. 1 transmission in a workplace, a worker who'd worked in a very close environment with a colleague transmitted to that individual. And then a religious group, a large religious gathering in the order of 250 people, and then again 2 days later 500 people, transmission to a small number, I believe 4 cases. What was interesting is that even in a large group of people, there wasn't a great deal of transmission. It was a group of people that seemed to have a lot of close contact in the way that they interacted, but it only gave rise to a very small number of people, those people who we believe were in really close contact with their fellow believers. The last healthcare worker case occurred in Canada around April 20th, and I will come back to that a bit later in terms of the investigation. The last case occurring in the community setting was on April 7th, and the last imported case on April 1st. So I think that there are grounds for that cautious optimism. I just want to say 1 or 2 points about the investigation, because this issue of case definitions has been a challenge because of our case definitions included contact with a known case. But we do have developed another case definition, a person under investigation, geo-linked, i.e. linked to a general area. And that will present a challenge to us in terms of especially those people who arrive, for example, in the US, who have been in Toronto, have a fever, have some respiratory symptoms, as to interpret if they've had no known contact with a case or a specific setting, whether they are a SARS case or not. And I again refer to that a bit later. But again, we're referring to probable cases, those in the numbers I referred to, those who have definite disease. In terms of laboratory diagnosis, we have carried out thousands of tests on now thousands of people. You may say, why thousands of people? It's because we have in fact tested probable suspect, also those who have traveled but are neither, and also then banked specimens. And we have some interesting results. Certainly those probable cases, we only have about 40% of those who are in fact positive for the coronavirus. And we have positive cases in those people who have travel history but no symptoms. It is a mystery. It is undoubtedly a challenge in terms of interpreting the epidemiology and interpreting the lab test of the coronavirus. And we certainly wish to look forward to collaborating internationally to answering the questions. We have sent out kits for testing to laboratories, but we're saying that's essentially at the moment a research tool, because as Dr. Gerberding said, a positive test may be indicative of something, a negative test is not. We put policies into action earlier on in terms of public health management, isolation or isolation/quarantine of suspect, of probable cases and their contacts. Infection control has been a huge issue, as Dr. Young would be able to explain to you in terms of the hospitals. And we've modified traditional infection control procedures. And in fact, we are having the benefit of 3 experts from people from CDC with specific expertise that are enabling Health Canada to work with Ontario to investigate the circumstances around healthcare worker transmission, which appears to have occurred even though those individuals have implemented the appropriate infection control guidelines. But that is being investigated right now, and it, again, is a challenge. We have, in terms of Health Canada, responsibility for federal workers ranging from our staff, but also quarantine officers, for example, but also customs agents, and giving advice to them has been very important. We've also given advice on clinical management related to particular treatments, and we've been watching this very closely because our special access program enabling physicians to have access to unlicensed drugs, and I believe that's the same in the US through the FDA, that special access program has just issued a notice essentially saying to physicians, because there is really no evidence that ribavirin, which is the antiviral that's been used most widely, actually really no evidence that is effective, and we have had numerous reports of adverse drug reactions from this drug that although we, the Special Access Program, would not refuse a physician further access to ribavirin, they would have to make a very, very strong case in the future. In terms of other responses, travel advisories, as you have done in the United States, and we are re-looking at those travel advisories, our activities at the borders, not dissimilar to those in the U.S., in terms of inbound, and again, airlines and ships have responsibilities for reporting. We also have yellow cards translated very early on into French, English, and simplified Chinese, and now we're collecting contact information on aircraft from the affected areas in Asia so that we can keep those if necessary. Outbound, because of the classification as Toronto as an affected area, we've had another color card, cherry-colored card, and posters at the Pearson Airport in Toronto. It is a challenge when one has to think of how to get to information to approximately 38,000 people a day. And we're continuing to refine that, and we will be enhancing that. And we've been working with the airlines to ask them to ask passengers about whether they've seen the cards. We're also working in terms of getting information to people who travel by rail, particularly those exiting the country. And we're working closely with CDC in terms of the issue of cruise ships. We will be enhancing outbound screening. We have a number of suggested procedures which we'll be looking at, and that is especially important in terms of the lifting of the travel advisory from the World Health Organization. I believe they're telling us that to ensure that we take the greatest steps to ensure that we do not, quote, export any more cases. We do have a different assessment about how many cases we have exported. There may have been 2 in our assessment, and those occurred at least 2 weeks ago now, which we believe is important. The World Health Organization advisory, as was mentioned, has been lifted and lifted as of tomorrow. We lobbied heavily to the World Health Organization in terms of clarifying the information they already had about that they used for their travel advisory, and we're very appreciative of the close collaboration which has taken place over the last few days on a number of video conferences and teleconferences, which has led to the advisory and also a visit from Health Canada staff and the Minister of Health from Ontario, who was today in Geneva. The issue for us, another issue for us now, is how to maintain a sustainable response. I'm sure Dr. Young will mention this. We hope we've turned the corner in terms of the requirement for quarantine and isolation. That has been a huge task for public health authorities, and the meeting which we're holding tomorrow and the next day, which I'll mention at the end, will be looking at what we should perhaps do in the future in terms of isolation, in terms of quarantine, and in terms of further infection control. Infection control will be very important because, as I've described, the challenge presented by once it gets out of into a hospital situation is a real challenge. Early detection has been mentioned earlier. Early detection by physicians is extremely important, getting information out to them. So isolation, rapid isolation of a suspect case is going to be one of the hallmarks of how we continue to control this, because we don't think it's going away. We hope certainly transmission internally in Canada will go away, but we will continue to have to deal with imported cases, I believe, even despite all the border controls we have. The other sustainable response we need is in communications. The transparency, the explanation of what is happening, the reassurance to the public in terms of the fact that we have methods to control, we have methods to contain and control. And we hope that that message gets out internationally And we hope that the lifting of the WHO travel advisory will aid that. Another issue has been the socio-economic consequences. And even before the WHO travel advisory, the economic consequences for Toronto and Ontario and Canada as a whole, because a number of people outside this country do not appreciate the size of the country and the fact that Toronto is a very small part of the country, albeit has a sizable population. And in terms of travel, the economic downturn, which has been tangible in Toronto, which again Dr. Young may refer to, it's a challenge for all levels of government in Canada in terms of trying again to encourage people, say that Toronto is a safe place to be, and encourage Torontonians to be out and about. There was a reference to baseball earlier on. The Blue Jays are selling tickets for $1 each tonight to get people out and about in Toronto. Lastly, I'd like again to re-emphasize the importance of collaboration within Canada with our provincial territorial partners, numerous federal government departments, and with the U.S., as has been mentioned, the liaison both from CDC in Health Canada and a staff person in Atlanta. We also now have a UK physician who is, in their parlance, embedded with the Health Canada Emergency Operations Centre. Internationally, close collaboration, obviously with the US, United Kingdom, Pan American Health Organization, and the WHO. And I'd like to agree with Dr. Gerberding in terms of the support of the lead that the WHO has given us in terms of international investigation and lab coordination. Finally, we are having an international meeting here tomorrow and the next day. We're very pleased that Dr. Gerberding will be able to spend at least some time with us, as will Dr. David Heyman from the World Health Organization. We intend to take stock, look at lessons learned, and move forward in terms of border issues, in terms of future epidemiology, infection control, public health management, and in fact the laboratory and science leading to the diagnostic tests and vaccines. So again, I really do appreciate, on behalf of the Government of Canada, your invitation to present to you, and I look forward to any questions that you may have.
Thank you very much, Dr. Gully, and that was a really excellent presentation, and not only comprehensive, but I think it settles out a lot of the issues in its substance and reflectiveness of the management of the issue. So we congratulate you on it and thank you for it. Dr. Young.
Thank you, Mr. Chair. I'm pleased to be here today to discuss the important issue of SARS and to tell you about the effective measures we have taken to contain and control this new disease in Ontario. I also wish to thank U.S. Consul General Antoinette Marwitz and her staff for their strong support to Toronto during our SARS outbreak. The Centre of Disease Control is also playing a key role both in our scientific efforts and also in supporting our position in regards to the WHO travel advisory against Toronto. I'm pleased to say that our science has been, that the WHO has accepted our facts and have agreed to lift that travel advisory. The problem for us in responding to SARS has centered on the fact that we know so little about it. What is it? What are its characteristics? How is it spreading? When are people infectious? How do we test for it? And how do we control and treat it? In the case of Toronto and the province of Ontario, we faced these questions very early in the known history of SARS and only knew that we were facing the challenge after the disease was already spreading in a local hospital. Our index case, as has been mentioned, was clear. A Toronto resident contracted SARS in an elevator in the Metropole Hotel in Hong Kong. That person happened to be returning to Toronto, became ill, and died. The 43-year-old son of that person went to hospital on March 16th, and I would note that date because it is only 4 days after the initial warning about SARS that was mentioned. And they went to hospital for treatment on March the 16th for treatment of what ultimately turned out to be SARS. While in the emergency department and after being admitted, this person was not in respiratory isolation. This person, in retrospect, is believed to have been highly infectious, and our cluster of cases takes off from this point. This person and the next 2 persons who were infected through contact in that emergency department all went on to infect large numbers of other patients, healthcare workers, and family members. It took us time to recognize the initial hospital case and to make the contacts from that case. Once that recognition was made, we imposed strict and effective isolation measures. By this time, however, because of the highly infectious nature of our early cases, enough staff and patients were affected that one hospital had to be closed to new admission, emergency cases, and transfers. We also started to alert the entire healthcare system. On March the 25th, we decided that a provincial health emergency should be declared in order to mobilize the full resources of the province of Ontario. We decided to act quickly and boldly to attempt to eradicate SARS from our community. We started by restricting activity in all of the hospitals in the province while we put in place stringent infection control procedures in all hospitals in the province. These included everyone, including staff, being checked for illness before entering a hospital. Staff were required to gown, glove, and mask in all patient areas of hospitals, and masks were provided for all patients entering an emergency department. Isolation was required for all respiratory patients in emergency departments until their conditions were determined. Initially, we also felt it necessary to stop all elective surgery. We stopped all visitors and volunteers from coming to hospitals, and we organized a new, very strict system of ambulance transfers between hospitals. On the community side, we also took strong measures. Public Health vigorously have tracked all contacts of SARS cases and imposed a 10-day isolation or quarantine on all contacts. This has meant the isolation or quarantine of more than 10,000 people for a 10-day period. If persons were found to be ignoring isolation orders, legal remedies were used. The public has also been encouraged not to go to work if they show early symptoms of SARS, including headache, malaise, or muscle ache, and not to go to work before they develop fever. Frequent hand washing has also been encouraged, and we have had press conferences each day at 3 o'clock in order to, again, be as transparent as possible with the public, educate the public, and tell the public everything that we know about SARS. This is done in order to foster a calm approach to the problem, and these measures continue to this day. Before our initial measures had time to take hold, the transfer of one of the highly infectious patients had occurred to a nearby hospital. This patient again was highly infectious, and this transfer resulted in more medical staff, their families, and other patients getting SARS. This hospital was also restricted in its activities. Our measures have proven effective. Both of the 2 most affected hospitals have now been reopened, and they have been through more than 2 incubation periods, 20 days, without any further spread or new cases. All of our known SARS cases are in our SARS units in our hospitals, and there are currently 37 patients in hospital with SARS. There are a small number of SARS patients finishing their recovery at home. March the 16th was the critical date for Toronto and our SARS outbreak. As well as the patients and staff becoming infected, relatives of one patient who took their patriarch to hospital that night also became infected. They subsequently visited doctors, a funeral home, and were involved in a religious community. This series of unprotected contacts took some time to trace and piece together and is referred to as the BLD cluster, named after the religious group. There are 31 cases within this group, and we ultimately isolated and quarantined more than 500 people. There have been no new cases from this group since April the 9th. It is important to note that our so-called community cases all track back to the original index case. We have had no sporadic or unexplained SARS in our community. Over the Easter weekend, we experienced a setback in our efforts. We had some incidents of SARS developing in medical staff working in SARS units. In one instance, a very difficult and long intubation in a SARS unit infected, we believe, 15 staff who were in attendance for that medical procedure. We immediately rewrote our isolation procedures for SARS units, and we invited Health Canada and the CDC to work with us to study this unfortunate event and to recommend the best ongoing infection control standards for our SARS units. We believe that these will become the standard for SARS treatment units around the world. And we certainly appreciate the fact that the CDC not only agreed to come, but are working diligently and well with our people. Finally, I will comment on where we are today. As of April the 28th, as I mentioned, we have 37 active SARS patients in our hospital, 17 fewer than 1 week ago. We have 18 active SARS patients at home finishing their recovery. We have had a total of 142 probable cases of SARS, but have very few cases each day now. We have had 20 SARS patients die, but all but one of these had significant other medical conditions, and most were elderly. There has been no spread of SARS through casual community contact for more than 20 days, and more than 20 days have passed since the last transmission among close contacts outside the healthcare setting. And I emphasize again, there has been no spread of SARS through casual contact at any time in Toronto. We continue to work with the CDC on infection control for our medical staff who are working in the SARS unit and with Health Canada. This, along with finding and isolating new travel cases as they come into Ontario, becomes our current challenge. The streets of Toronto are safe from SARS. They are as safe as the streets in London, Paris, or Washington. In fact, a BBC reporter told me last Saturday that he saw more masks and more concern about SARS in London, England, than he did in Toronto. That was as we walked through the streets of Toronto and people were out and about on the weekend. And as Dr. Gully mentioned, there will be a full Sky Dome tonight out at the baseball game. But the lesson for all of us is that it only takes one case to start a new breakout. And therefore we must be vigilant and we must remember that. We can best, as you asked, Mr. Chair, defend the border by working together, by sharing our experiences, by sharing scientific data, and by taking common approaches. Thank you for this opportunity to discuss our experience in Ontario.
Thank you, Dr. Young, and thank you also for that excellent presentation. And I think it's a presentation that can bring a fair amount of calm to the situation, and that's important because you reflect statistical facts which show that the virus can be contained. And I guess that's my first question to both doctors. Do you feel you've got a handle on it in Canada? And as you said, Dr. Young, there may be somebody else who comes in with the disease, but do you feel as of this time that you've got it under control and have a handle on it?
Let me speak to Ontario first, and perhaps Dr. Gully can speak for the rest of Canada. We do feel we have a handle on the situation in Ontario. We acknowledge that we are working in our SARS units with medical staff. This is an age-old problem in infectious situations around the world in any unit, and we believe and have reason to be optimistic that our new measures are taking hold, but we're prepared to do whatever is necessary and whatever is recommended by the study group now in order to make our units as safe as is humanly possible. By going more than 2 cycles of this disease, both in the community and within the affected hospitals, we believe that we have succeeded in getting it out of our healthcare system, and as far as it went into our community, which I again remind people is only by direct contact, it is out of the community and it is out of our general healthcare system. But those remain the risks if a case comes in and it is in control, but those are the risks for every jurisdiction everywhere. Dr. Gully?
I agree with Dr. Young that we do have it under control. I also echo his words in terms of the fact that from now on in, we have to ensure that any new cases that arrive, probably from abroad, have to be dealt with the utmost care. Again, close contact, but the healthcare setting, as has been the case in numerous situations in the past with emerging infectious diseases, the hospital settings are ones in which are most vulnerable. So that I think that it's important that even though it'll be a long time before we get a vaccine, maybe it's a question of the diagnostic test, we still as was described by Dr. Gerberding, we have traditional methods of public health, isolation in the community, isolation, quarantine, and infection control. And these have been applied through a huge amount of work, but have been applied and have worked.
Do you have a different approach towards informing and trying to get the participation of people who are coming into your country from China or other areas where there's a high degree of infection than we have? We are giving out this yellow card, which was noted by Dr. Gerberding. Is that your process? You mentioned that you have an information card, but do you do a more aggressive screening than that in light of your experience? Dr. Gully?
We still use a yellow card, but what we did do was to put it back onto the airplane so that flights from Hong Kong and from China and Taiwan, in fact, people on those planes get the yellow cards on planes, and in addition, we do collect contact information on those flights, which are then collected when people disembark. We have, in a similar way to you, quarantine officers meeting flights to detect individuals who are obviously sick, and they obviously expect the airlines to cooperate in terms of informing us of sick people. So we have put it back, put it back in the system a bit more in terms of on planes, so that people have much longer to digest information and to perhaps ask questions even on a flight, and perhaps self-identified as being sick, so then they can be dealt with when they disembark.
How are you handling people who are transiting through a different country that does not have the issue?
That is a challenge, and certainly in terms of individuals transiting through the U.S., we obviously are relying on the process which we know that the U.S. is undertaking. We have taken the opinion that we have to put things in place which are there's a cost and a benefit to these, and we feel that because we haven't had an imported case since April 1st, that what we have in place is working, and there have been certainly calls for us to do a lot more, and we had to decide what was doable, where we thought the most effort that we should put in, and we believe that we've done that. In terms of outgoing, we may be making further enhancements of that, in particular because of the call from the World Health Organization as relating to exported cases.
What would you say are the 3 things or 4 things, or even 5 if you have them off the top of your head, that we in our country should learn from your experience? You've developed protocols, as you said, that you expect to be generally acceptable, but if you both could sort of respond to that question.
Perhaps also.
I believe, the protocols that we set up in terms of with our partners, obviously in the province and local health departments, have worked. And I think that it was more, as I said, the fact that it was into the hospital situation in Toronto before we all were aware of it, so that I think that what you would do in terms of public health management and infection control is what we would do. I hope now that you don't get in the same situation as we do in terms of not identifying a person who actually came into the country with obvious symptoms and obvious disease. So Dr. Young may want to talk about the quarantine isolation experience, which is directly related to Toronto.
Dr. Young?
Yes, Chair. I would advocate several things, and some of them you have heard of. Full, open, and transparent communication is number one, because it keeps the calm in the community and it keeps people doing what we ask them to do. So that certainly is very important. The actions that need to be taken when there's a problem, we held a view at the time we declared the provincial emergency that we had very little time to act and that we had to act properly the first time. So the actions we took were firm, they were bold, and in some cases they were described as an overreaction. And I make no apology for overreacting. I think they have to be when you are faced with this kind of problem, because you only get sometimes one chance to deal with it. You then need to mobilize, in fact, large parts of the government, because a problem like this affects much more than just public health. It involves the whole healthcare system, doctors' offices, hospitals, long-term facilities, because this disease is potentially fatal, entering into a nursing home or home for the aged or chronic care facility. It means other government ministries, because it has such a broad, overarching government effect on so many departments. And then you need to use, I believe, the things that have worked for us: isolation, close contacts. But isolation has to be, again, lots of people and more people isolated than you would think necessary, and there's a big education in that. There strict infection control within hospitals, and then re-education of the medical community. They have to approach SARS from the point of view of every case that comes in with a respiratory problem is SARS until proven otherwise, and a lot of more isolation than until that's proven. And finally, trying to get the community to understand that if there is a firm risk in the community, people need to stay home when they're sick until the issue is sorted out, because that allows people to be isolated in relative terms so that you don't have hundreds of contacts while somebody is out with a fever and sick.
Well, that's an excellent set of recommendations, and I'm sure that our folks will be following that closely, as the protocols that you've developed. And I think it's good that you're having this meeting. Is it tomorrow or the next day?
Tomorrow and the next day, both.
Well, we'd like to give you some tourism and send a few staff folks up from this committee, if that's appropriate, to
very much
observe and learn, because you've obviously got a lot to teach us on this. Just to reiterate, your last case that you identified was a public event versus a non-hospital event, was on April 9th?
April the 9th. April the 9th.
And the incubation period is 10 days?
That's correct.
So you're fairly confident that as far as public events are concerned, this is under control?
That's correct. We're 20 days out today, so that we're confident that our community problems, hopefully permanently, are behind us.
Well, we congratulate you, and again, Dr. Gully and Dr. Young, I thank you very much for being willing to take the time to participate in this hearing. It means a lot to us here in the United States. I know it required some special dispensation in Canada to be able to do this. We very much appreciate this cooperation, and we look forward to continuing it. And if we can be of help to you, you tell us. You've obviously been of great help to us. Thank you very much.
Thank you, Chair.
Thank you.
This hearing is adjourned.
He didn't say anything.
Shall we?
Yeah, I can cut this. Huh? I can cut this.
Still to come tonight here on C-SPAN 2, President Bush remarks about a global HIV/AIDS initiative. After that, you'll hear from Senate leaders about their legislative agenda. Later, a discussion on congressional districts and race. The Supreme Court heard a case on the subject earlier today. Now the president. He came to the East Room of the White House to talk about a proposed $15 billion program to fight AIDS. This is about 20 minutes.